Myocardial infarction. Myocardial infarction, also commonly referred to as a heart attack, is the death of cardiac muscle due to prolonged severe ischemia, which is a restriction in blood supply to tissues, causing a shortage of oxygen that is needed for cellular metabolism. The heart's main job is to pump blood around the body, but the heart also needs blood, and so it also pumps blood to itself using the coronary circulation, which is the circulation of blood in the blood vessels that supply the heart muscle. Heart attacks happen when these small arteries become blocked and stop supplying blood to the heart tissue. The blockage is most often a buildup of fat, cholesterol, and other substances, which form a plaque in the arteries that feed the heart. In most instances, disruption or erosion of pre-existing atherosclerotic plaque serves as the nidus for thrombus generation, vascular occlusion, and subsequent infarction of the perfused myocardium. Plaques rupture when they are unable to withstand mechanical stresses generated by vascular shear forces. The composition of plaques is dynamic and can contribute to risk of rupture. Thus, plaques that contain large areas of foam cells and extracellular lipid, and those in which the fibrous caps are thin or contain very smooth muscle cells or have clusters of inflammatory cells, are more likely to rupture. These are referred to as vulnerable plaques. Collagen is the major structural component of the fibrous cap and accounts for its mechanical strength and stability. Thus, the balance of collagen synthesis versus degradation affects cap integrity. Collagen in atherosclerotic plaque is produced primarily by smooth muscle cells, so that loss of these cells results in a less sturdy cap. Adrenergic stimulation can increase systemic blood pressure or induce local vasoconstriction, thereby increasing the physical stresses on a given plaque. When the plaque is disrupted, platelets adhere, aggregate, and are activated, releasing thromboxane A2, adenosine diphosphate, and serotonin, causing further platelet aggregation and vasospasm. Activation of coagulation by exposure of tissue factor and other mechanisms adds to the growing thrombus. Within minutes, the thrombus can evolve to completely occlude the coronary artery lumen. Loss of blood supply has profound functional, biochemical, and morphologic consequences for the myocardium. The outcome depends predominantly on the severity and duration of flow deprivation. Within seconds of vascular obstruction, aerobic metabolism ceases, leading to a drop in adenosine triphosphate and accumulation of potentially noxious metabolites in the cardiac myocytes. Because of the exquisite dependence of myocardial function on oxygen and nutrients, myocardial contractility ceases within a minute or so of the onset of severe ischemia. Such loss of function actually precipitates heart failure long before myocyte death occurs. Ultrastructural changes including myofibrillar relaxation, glycogen depletion, cellular and mitochondrial swelling are also seen. These early stages are reversible. Only prolonged ischemia lasting at least 20 to 40 minutes causes irreversible damage and coagulative necrosis of myocytes. This delay in the onset of permanent myocardial injury provides the rationale for rapid diagnosis in acute MI to permit early coronary intervention to establish reperfusion. The earliest detected feature of myocyte necrosis is the disruption of the integrity of the sarcolemmal membrane, allowing intracellular macromolecules to leak out of necrotic cells into the cardiac interstitium and ultimately into the microvasculature and lymphatics. This escape of intracellular myocardial proteins into the circulation forms the basis for blood tests that can sensitively detect irreversible myocyte damage and are important for managing MI. Due to the myocardial perfusion pattern from epicardium to endocardium, ischemia is most pronounced in the subendocardium. Thus, irreversible injury of ischemic myocytes occurs first in the subendocardial zone. With more extended ischemia, a wavefront of cell death moves through the myocardium to encompass progressively more of the transmural thickness. Transmural infarction is the infarction that involves the whole thickness of the heart muscle, from endocardium to epicardium. Subendocardial infarction, as the subendocardial zone is normally the least perfused region of myocardium. This area is most vulnerable to any reduction in coronary flow. Reperfusion is the restoration of blood flow to ischemic myocardium threatened by infarction. The goal is to salvage cardiac muscle at risk and limit infarct size. Not only does reperfusion improve short and long-term survival, but it also impacts short and long-term myocardial function. Thus, prompt reperfusion is the preeminent objective for treatment of patients with MI. This can be accomplished by a host of coronary interventions, that is, thrombolysis, angioplasty, stent placement, or coronary artery bypass graft surgery. Indeed, thrombolysis can remove a thrombus occluding a coronary artery, but does not alter the underlying atherosclerotic plaque that initiated it. In contrast, percutaneous transluminal coronary angioplasty with stent placement not only eliminates a thrombatic occlusion, but also relieves some of the original obstruction and instability caused by the underlying disrupted plaque. Coronary artery bypass graft surgery provides a new conduit for flow bypassing the area of vessel blockage. Clinical features. MI is diagnosed by clinical symptoms, laboratory tests for the presence of myocardial proteins in the plasma, and characteristic electrocardiographic changes. Patients with MI classically present with prolonged chest pain, described as crushing, stabbing, or squeezing, associated with a rapid weak pulse, profuse sweating, and nausea and vomiting are common. The laboratory evaluation of MI is based on measuring the blood levels of proteins that leak out of irreversibly damaged myocytes. The most useful of these molecules are cardiac-specific troponins, T and I proteins that regulate calcium-mediated contraction of cardiac and skeletal muscle, and the MB fraction of creatine kinase. The diagnosis of myocardial injury is established when blood levels of these cardiac biomarkers are elevated. Troponins I and T are not normally detectable in the circulation. Following an MI, levels of both begin to rise at 3 to 12 hours. Troponin T levels peak somewhere between 12 and 48 hours, while troponin L levels are maximized at 24 hours. Creatine kinase is an enzyme expressed in brain, myocardium, and skeletal muscle. It is a dimer composed of two isoforms, designated M and B. While MM homodimers are found predominantly in cardiac and skeletal muscle, and BB homodimers in brain, lung, and many other tissues, MB heterodimers are principally localized to cardiac muscle, with considerably less amounts found in skeletal muscle. Thus, the MB form of creatine kinase, CK-MB, is sensitive but not specific, since it can also be elevated after skeletal muscle injury. CK-MB begins to rise within 3 to 12 hours of the onset of MI, peaks at about 24 hours, and returns to normal within approximately 48 to 72 hours. Do not forget to like the video and subscribe to our YouTube channel.